asthma or rhinitis. Eczema, an itchy red skin rash, may be caused by food allergens or exposure to house dust mites. We're going to discuss about the treatment of immediate hypersensitivity. Avoidance of known allergen is the first line of defense. This includes environmental interventions such as encasing mattresses and pillows in allergen-proof covers and not allowing pets inside the house. Drugs used to treat immediate hypersensitivity vary with the severity of the reaction. Localized allergic reactions such as fever, hives, or rhinitis can be treated easily with antihistamine and decongestants. Asthma is often treated with a combination of therapeutic reagents including antihistamines and bronchodilators, followed by inhaled corticosteroids. Systemic reactions require the use of epinephrine to quickly reverse symptoms. Another approach to treatment involves immunotherapy or hyposensitization. Very small quantities of sensitizing antigen are injected into the patient with the idea of building up IgG antibodies. Individuals with moderate to severe symptoms are given weekly doses of antigens that gradually increase in strength. The blocking antibodies form circulate in the blood and combine with antigen before it can reach IgE-coated cells. In addition, it appears that T-cell mediated suppression occurs due to the action of T regulatory cells, thus decreasing synthesis of IgE. A new approach involves use of an anti-IgE monoclonal antibody. This antibody combines with IgE at the same site that IgE would normally use to bind to receptor on mast cells. Blocking of this site does not allow IgE to bind to mast cells, thus helping to alleviate allergic symptoms. Omalizumab was the first such antibody to be approved for therapeutic use in the United States. In addition to blocking the release of mediator from mast cells, downregulation of FcRI receptors occurs, thus curtailing the response. Anti-IgE therapy has been successful in treating moderate to severe asthma and show much promise for the future. Now we're going to discuss about the testing for immediate hypersensitivity. Now let's go to in vivo skin test. Testing for allergies or immediate hypersensitivity can be categorized as in vivo or in vitro methods. In vivo methods involves direct skin testing, which is the least expensive and most specific type of testing. Cutaneous and intradermal tests are the two skins most often. In cutaneous testing, or a prick test, a small drop of material is injected into the skin at a single point. After 15 minutes, the spot is examined and the reaction is recorded. A positive reaction is formation of a wheal that is 3 mm greater in diameter than the negative control. A negative saline control and a positive control of histamine should always be included. Cutaneous testing uses 1,000-fold higher concentration than intradermal test, but a lesser amount of antigen is used, thus decreasing the chances of an anaphylactic response. Intradermal tests use a greater amount of antigen and are more sensitive than cutaneous testing. However, they are usually performed only if prick tests are negative and allergy is still suspected. An extremity such as an arm to which a tourniquet can be applied is used to stop an unexpected systemic reaction. A 1 ml tuberculin syringe is used to administer 0.01 to 0.05 ml of test solution between layers of the skin. The test allergen is diluted 100 to 1,000 times more than the solution used for cutaneous testing. After 15 to 20 minutes, the site is suspected for erythema and wheal of formation. A wheal has a 3 mm greater than the negative control, is considered a positive test. Skin testing is relatively simple and inexpensive, and it's lend itself to screening for a number of allergens. However, antihistamine must be stopped 24 to 72 hours before testing, and there is a danger that a systemic reaction can be triggered. In addition, skin testing is not recommended for children under 3 years or of age. Now we're going to talk about the in vitro test, total IgE. The testing principles. In vitro test involves measurement of either total IgE or antigen-specific IgE. They are less sensitive than skin testing but usually are less traumatic to the patient. Total IgE testing has become more important as a screening test before a patient is referred to an allergy specialist, because it is a good indicator of the likelihood of allergic disease. The first test developed for the measurement of total IgE was the competitive radioimmunosorbent test. The radioimmunosorbent test, or RIST, use radio-labeled IgE to compete with patient IgE for binding sites on a solid phase coated with IgE. RIST has largely been replaced by non-competitive solid phase immunoassay due to the expense and difficulty of working with radioactivity. In non-competitive solid phase immunoassay, anti-human IgE is bound to a solid phase such as cellulose, a paper disc, or a microtiter well. Patient's serum is added and allowed to react, and then a labeled anti-IgE is added to detect the bound patient IgE. This label is an enzyme or a fluorescent tag. The second anti-IgE antibody recognizes a different epitope than the recognized by the first antibody. The resulting sandwich of solid phase anti-IgE, serum IgE, and labeled anti-IgE is washed, and the label is measured. In this case, the amount of label detected is directly proportional to the IgE content of the serum. Although the second incubation doubled the time of the assay, the sensitivity of this type of testing is excellent, and the results are minimally affected by the presence of non-specific serum factor. Total IgE testing is used clinically to aid in diagnosis of allergic rhinitis, asthma, or other allergic conditions that may be indicated by patient symptoms. It serves as a screening test to determine if more specific allergy testing is indicated. It is also important in diagnosis of parasitic infections, bronchopulmonary aspergillosis, and hyper-IgE syndrome, a condition in which excessive amount of IgE are produced. Interpretation of total IgE results. Going to discuss about that. The total IgE values are reported in kilo international units, IU, per liter. 1 IU is equal to a concentration of 2.4 mg of protein per milliliter. IgE concentration varies with the individual's age, sex, and smoking history, and his or her family history of allergy. Levels also normally as a function of exposure to allergens. In infants, normal serum levels of IgE are less to the allergens. In infant, normal serum levels of IgE are less than 2 kIU per liter. increase up to 10k IU per liter are indicative of allergic disease. After the age of 14 years, IgE levels in the range of 400 kLUL are considered to be abnormally elevated. A cutoff point of 100 IU, however, is frequently used in testing to identify individuals with allergic tendencies. Although two-thirds of adults who have allergic symptoms would fall into this category, the one-third might be incorrectly diagnosed. Additionally, IgE level may be elevated due to the conditions such as helminth infections, Wisconsin syndrome, DiGeorge syndrome, and hyper-IgE syndrome. Thus, total IgE level must be interpreted in light of the patient's personal and family history, and they should not be regarded as an absolute predictor of allergy. Although measurement of total IgE levels can be useful screening tools, allergen-specific IgE is more helpful in actual treatment of the individual. Now we're going to talk about the antigen-specific IgE testing. Now, its testing principle, the original commercial testing method for determining specific IgE was known as the radioallosorbent test. Introduced in 1966, principle of the test remains the same, but never newer testing methods involve the use of enzyme or fluorescent labels rather than radioactivity. Allergen-specific IgE testing is safer to perform than skin testing and is easier on some patients, especially children or apprehensive adults, and thus sensitivity now approaches that of skin testing. It is especially used in detecting allergies to common triggers such as ragweeds, trees, grasses, molds, animal dander, milk, and egg albumin. Allergen-specific of IgE testing is a non-competitive solid phase immunoassay in which the solid phase is coated with specific allergens and reacted with patient's serum. A carbohydrate solid phase such as paper cellulose disc, agarose beads, agarose hydrate solid phase such as paper cellulose disc, agarose beads, or microcrystalline cellulose particles seems to work best after watching to remove unbound antibody. A labeled anti-IgE is added. Traditional RAS used the radioactive label, while newer tests use an enzyme or fluorometric label. A second incubation occurs, and then after a washing step, the amount of label in the sample is measured. The amount of label detected is directly proportional to the amount of specific IgE in the patient's serum. Controls and standard are run in parallel with patient's serum. So in figure 13-3 show a comparison of the total and allergen-specific IgE testing. Now we're going to talk about the interpretation of allergen-specific IgE results. Newer commercially available testing systems such as Pharmacia and Upjohn's Immunocap and Diagnostic Product Corporation Imulite have greatly increased the sensitivity of in vitro allergy testing. IgE can now be measured quantitatively and concentration as low as 0.35 KIU per liter can be detected. It is important to run positive and negative result control to aid in the interpretation of test results. A negative test may be used to confirm the absence of a specific atopic disease, and this has a higher negative predictive value than total IgE testing. However, in a positive test, the quantity of antibody measured does not necessarily correlate with the severity of disease. This type of testing is very useful to determine common food allergies and sensitivity to the venom of stinging insects such as honeybees, yellow jackets, wasps, and hornets. But it is more difficult to